Thank you, Mr. Chairman. I appreciate it so very much, and I thank the panel as well. A few questions for both of you. Can both of you discuss your experiences in transitioning to value-based care outside of your work on the Physician-Focused Payment Technical Advisory Committee, and how has that influenced your view of what advanced alternative payment models can deliver? Now, I know that some of these things have been covered, but if you could respond, I'd appreciate it.
Sure. Well, I will speak to my experience, which is quite different from Jeff's, but I actually used to work in a very large health system, so had some experience there as they were trying to transition their practices. But more recently, I've worked in multi-stakeholder groups in various communities from Hawaii to Maine, where they are bringing together employers, health plans, providers, patients, state governments, others, to try to come up with payment changes that actually meet all the stakeholders' needs. So is it getting value for the money? Is it improving patient outcomes? And are clinicians actually happier providing this care? And is it better suited? Are the barriers being removed? It's actually that multi-stakeholder alignment that enables the transition. So that is, and we have tried various models, ACOs, bundles, patient-centered medical homes, and implemented those in different communities.
Thank you.
So in my experience supporting large physician practices, multi-specialty group practices, there's a tremendous amount of inertia to work with the physicians and the clinicians to get them to change their practice styles and move away from fee-for-service, volume-driven practices to focus more on outcomes. The models I've deployed in my former leadership roles relative to supporting physicians and clinicians, paying them for quality outcomes, paying them for collaboration with their colleagues, paying for their utilization of electronic health record. There has been, and I think there continues to be, some challenges with galvanizing the level of interest. There's challenges with the data that typically we hear from the physicians that as they move away from volume, you know, does the data you're sharing with me that you're now going to pay me for accurately reflect the work that I'm doing? So there's, I think it's washing out, but there was obviously on the front end of moving from volume to value a healthy dose of skepticism from the physicians. Well, you're going to pay me differently, but am I actually going to get paid for the work I'm doing? And so it is very challenging, but I think right now what I'm seeing is that the mindset of the physician and the clinician is they know they need to do it. They know they need to move away from the fee-for-service environment, pure fee-for-service. And the question is, how do we do it? And at what pace do we do it? And what tools are you going to provide me so that you're not overburdening my practice? Elizabeth talked about the $40,000 per physician just to monitor and track quality. But I would also argue there's another 750 hours, I believe, that was in that same study that each physician has to devote to monitoring and managing and measuring and reporting quality. I'm here to say that as a health plan, we had 188 quality metrics that we were holding our physician community accountable for. I don't want to get into the weeds, but I'm sure you think that is not optimal. Yesterday, the board of Blue Shield approved moving to an integrated healthcare association set of metrics, 34, and we are going to lead the way in the state and try and get a standardized set of metrics, 34 metrics, it's not boiling the ocean, to actually have and change outcomes and drive this value and try and take the burden away from the practitioners.
Could I just add, I think that is absolutely essential to not only reducing burden and cost, but actually allowing physicians to accelerate improvement. And the other element of that report is that there was only 5% overlap in commercial plans for using the same measures. If they could do what Blue Shield of California did and agree to use a common set, that makes life easier for physicians, and it can lead to better care at lower cost. I think it is just an exemplary move, and that one that could easily be replicated around the country if folks were willing to do that.
Very good. We'll take a hard look at that and I'll submit my questions for the record because I don't have time. Thank you, Mr. Chairman. Appreciate it.
Chair, thanks, gentlemen. Gentleman yields back. Chair